and good morning to everyone. You're warmly welcome to this platform, and I would request that you please type your names in the chat and click on the link so that we can identify the world map and you can locate where you are calling in from. Dana, thank you for putting your name in the chat. I think you're the very first to put your name in the chat. Right. Dr. Said Sania from Zanzibar, thank you very much for putting your name in the chart. Can we all type our names in the chat to just make introduction easier? And kindly click on the link in the chat so that Christine, nice to see you. Thank you for joining the meeting. Right. Dr. Noha from Egypt, you're very welcome. Thank you. Dr. Rana from Bangladesh, really great to see you. Dr. Nicholas Luhman, I know you're in the room with me. Dr. Mpundu, you're welcome. Meg, good morning again, welcome. I'm just giving people 1 minute to settle down and then we really get started. Dr. Lee from China CDC, you're very welcome. Thank you for joining. Can we keep the names coming in? I see 51 people on the line and this is really great and exciting and we are on time. Okay, so I think we can start now. It's 9:02. Dr. Mola from Bangladesh, Dr. Adshara from Thailand, you're very welcome. So my name is Dr. Fumi Leshi. I'm the hepatitis team lead for the Global Hepatitis Program. And I'm here with my colleagues, Dr. Diana Finey, Dr. Nicholas Luhman, and Dr. Sandy Min, and Dr. Philippa Easterbrook, and Lydia Kawazudub. We are excited that you're joining us from different parts of the world, and we will just quickly do a check to make sure that sound is clear for all to hear. Dr. Ekundayo from Nigeria, you are very, very welcome. So please scan the QR code or follow the link in the chat to let us know where you're joining from. Next slide. And before we get started, I will invite my colleague Diana to give us a few housekeeping tips for the duration of the seminar. Thank you, Diana.
Thank you, Fumi. So just everyone is aware, we do have interpretation services available in French. And to be able to hear that, you should click on the interpretation icon on your screen and select the language that you want to listen to. You can also enable the feature for live transcriptions so as to be able to capture the text of all the scripts of the session as it goes. We welcome you to use the chat feature on the panel so as to type in your questions regarding to the topic, and we'll be able to provide any responses to the question raised. And please do rename your Zoom ID if you have not yet done so to identify yourself, preferably using your first name, last name, and the country where you're joining us from. Just to let you know that this session is being recorded. The recording, as well as the PowerPoint and other resources shared in this session, will be shared to everyone after the webinars. You'll also receive a certificate of attendance, and would like you to be aware that Project ECHO, who is partnering us with this session, does collect information on participation, as well as the question and answers that you put in the comments. And before we go on with the program today, just so that we remind you, there's a QR code posted and also the link shared in the chat. Kindly go to the link on the which will take you to a different web link. Once you join the website, click on the map by pressing a pin on the country or the place where you're joining us from. And once you do that, please do come back to the Zoom screen.
Thank you very much, Diana. And I welcome all very warmly to this interactive webinar series, which is called Dialogues for Viral Hepatitis Elimination. And I will quickly hand over to my boss, Dr. Meg Doughty, the Director of HIV, Hepatitis, and STI departments from WHO here in Geneva. So Meg, you're very welcome, and we invite you to take the floor.
Thank you so much. And it's really great to see almost 60 people online. And I'm sure we'll get there at some point. And I'd like to welcome you all from all around the world to this meeting and this first of what we're calling the Dialogue for Viral Hepatitis Elimination. This webinar and meeting is specifically designed for program officials and policymakers at the country level to provide a platform to share experiences and learn from the best practices from different regions and populations in their context. And I think this platform really came up as a result of feedback from all of you during the time when we had the World Hepatitis Summit here in Geneva in June 2022, where several country officers expressed the need for a forum like this. And we hope that you will work with us to co-create and create a sustainable platform, and also to build a network and a communities of practice to support country progress towards elimination. We are currently working with our colleagues at the regional offices of WHO to ensure that all the regions have the opportunity to participate despite the time zone. So this is our first foray into seeing how we can do this, and it's early morning for some, late for others, and evening for others. But I do think that the communities of practice have been incredibly important in many fields. And it's exciting to see that you're interested in this and that we can keep the momentum around elimination going for hepatitis. In this first meeting, we'll be focusing on person-centered care, and you've probably heard these terms quite a bit. Sometimes we wonder what this means and how we're going to make it happen at the country level. So here we'll be exploring some of the linkages and integration that have been done already in your countries, and some of the opportunities and synergies we can use with either working with HIV or other programs, primary care, for example, where trying to focus on ensuring that there's adequate hepatitis coverage is going to be important and that the person gets the care they need. You may be aware that we have updated global health sector strategies on HIV, hepatitis, and STIs that went through the World Health Assembly last year. These strategies take us to 2030, and they prioritize some of the commonalities around different diseases and also looks toward the integration across systems and sectors and building partnerships so that there can be meaningful community engagement in an approach and in the goal of reaching our ending hepatitis by 2030. And I've always said that hepatitis is the one that is most in reach to be able to make our 2030 targets if we actually do the work needed and we use the tools that are available. And we know that we've made great progress towards elimination of hepatitis C and in some places hepatitis B in many countries. There are several pilots scaling up that have national plans around the world. And we've also gone through a report that looks at 7 countries and how they're piloting the interim guidance on how to validate elimination of hepatitis B and C. And we know that there are many countries who are making such great progress. So here we hope to really inspire you all to find your own commitments within your countries and to bring your national hepatitis responses to the point where you have the aspiration of elimination. So in 2021, right before the World Health Assembly, we pulled together a report to take stock of where we are with the hepatitis B and C response. And we know that there's still 300 million people living with viral hepatitis B and C who have not been reached with the services that they need. And to be honest, we have only 10% of those with hepatitis B tested and nearly 20% of hepatitis C. To reach our targets, we're going to have to increase case finding for sure, but then also use the tools for treatment and prevention. We will have the opportunity during these discussions to highlight some of the challenges you've been seeing and that have stopped you from reaching the greatest potential you can towards elimination. And that might help if you explore your challenges. Other countries could be able to help you find solutions, and/or we can see what are the solutions from countries who have been able to overcome these challenges. And with that, we hope that we can have some innovative solutions to reach our 2030 elimination goals. So during this first webinar, our key speakers today will be Dr. Sandhya Kabra, the Deputy Commissioner, and Dr. Partha Rakshif, the Joint Director of the Ministry of Health and Family Welfare, both from the Government of India, who will be sharing insights into the National Hepatitis Program in India and how they're building a sustainable and integrated program. We heard a bit of what they were doing in terms of integrating hepatitis into primary care and UHC during the World Hepatitis Summit. And we'd like to hear more about how they built off of this program and their successes thus far. We will also have Professor Wael Abdel Razek, the Deputy Executive Director of the National Committee for the Control of Viral Hepatitis in Egypt, and who will be presenting some of the reflections on the Egypt Hepatitis C program and how they are building the capacity for integration. All of these speakers are going to provide you with quite a bit of experience and also be able to show you how you can move from small programs to very large programs in a matter of a very few years. So we'd also like to say thank you to the collaboration with ECHO, Project ECHO, who have been supporting and will sustain this platform for monthly meetings. This has been really helpful for us, and I know they will explain their program to you in a moment, but I do think that we know that it's been a platform that's been very helpful for connecting people around COVID, and we expect the same for hepatitis. Excuse me. So again, I want to also thank our really dedicated hepatitis team, including Fumi, and we've got Diana, Nicholas, Philippa, Sandy, and all sorts of support staff supporting the hepatitis team to make sure that this is a reality. So I'd like to pass back to you, Fumi, and thanks so much that I can be with you on this morning. Bye-bye.
Funmi, I think you're muted. Do you want me to go ahead and start?
No, just a minute. Thank you for the wonderful welcome and your overwhelming support of this interactive webinar series. We hope you will join us for this very first session of Dialogues for Viral Hepatitis Elimination. I will now invite Amy Groom from the Project ECHO to share with us the success of their project and how they've been working all over the world to create this dynamic learning environment. Thank you very much, Amy, and over to you.
Great. Thank you so much, Funmi. Thank you, Meg. It's such a pleasure to be here today and see so many people joining from around the globe. We're delighted to be working in this partnership with the WHO Global Hepatitis Program to support this dialogue and an interactive learning series. I also just want to acknowledge my colleagues from ECHO India, who are providing the IT support and behind the scenes support for this session today. My name is Amy Groom, and I'm the Director of Immunization Initiatives with Project ECHO, and I'm based in Albuquerque, New Mexico in the United States. Next slide, please. So just a little bit about the ECHO model. ECHO stands for the Extension for Community Healthcare Outcomes, and it's a virtual learning model that supports collaborative problem solving and interactive learning built around 4 pillars. The first is that it uses technology like the Zoom platform we're using today to be able to connect people who are geographically dispersed to create virtual communities. And one of the real advantages it has is the video conferencing piece. So if you have a moment to turn on your camera and at least say hello and see the faces of your colleagues, that's always a really nice way to be able to create this sense of community. We share best practices such as guidelines or evidence-based practices, and that's another key component of the ECHO model, and this typically occurs through a brief lecture from a subject matter expert, of which there are many on this call today. But the heart of the ECHO model is really about you, the participants. And this comes from when participants such as yourself present cases or real world issues or challenges that you're experiencing in your work. And this allows your peers to share their knowledge, and it really engages the group and the community in that collaborative problem solving that helps to identify real world solutions to real world problems. And then, of course, the ECHO model does include a monitoring and evaluation component to promote continuous quality improvement of the learning sessions. So at the end of the session, you'll see a link to a post-session survey, and we'd love for you to fill that out to help continue to improve the program. Next slide, please. In the ECHO model, everyone is teaching and everybody is learning. And it's this interactive sharing of information that really creates a community of learning that helps to support the collaborative problem solving. So we're really hoping all of you will bring your expertise, your knowledge, your questions to these sessions moving forward so that everybody can be learning. Next slide, please. And finally, I did just want to share a map of the ECHO partnerships occurring around the globe. This isn't the work of ECHO. This is the work of our partners like WHO, and many of you in your countries may have worked with ECHO and have ECHO programs running. And you can see that ECHO has been adopted by over 600 of the world's leading health organizations and academic institutions. And there are over 2,400 networks running in 76 countries, with participant learners joining from 190 countries. So we're really delighted to be here today and supporting this partnership with the hepatitis program, and look forward to having them be part of the ECHO network family. So thank you so much. Back to you, Funmi.
Thank you so much, Amy. It's just been a pleasure listening to you talk and talking about the ECHO program. And I just want to reiterate a statement you made, that the participants, the 71 people, they are the center of this dialogue, and we really look forward to communicating closely with them. So for this session and for the entire interactive WHO Ministry of Health interactive webinar series, the objectives are to develop this interactive platform to promote country-to-country learning and foster strong collaboration for viral hepatitis elimination. Also to recognize and document country successes and achievements towards hepatitis elimination in different regions and contexts. And that is why we're particularly excited that we have people joining us now from every region of the world, over 36 countries identified already. The third objective is to communicate and strengthen in-country adaptation and implementation of global hepatitis strategies, guidance, and guidelines. And finally, to identify operational challenges or priority interventions and explore innovative solutions and opportunities for WHO strategic and technical and financial country support for impact. So I would swing in quickly into the topic for today, which is person-centered care for viral hepatitis elimination. And this is the outline of my presentation. We'll highlight very briefly background and provide a situation report for 2021 and how we plan to close the gap to 2022 using the new global health sector strategy, and highlight examples of linking and integrating hepatitis services with other health services, and excitingly for us, reflections from hepatitis program managers and policymakers from 30 countries, and then the next steps for 2023. So in terms of backgrounds, I think we all know about the huge global burden of viral hepatitis B and C and hepatitis Delta. We're constantly reminded not to forget the importance of hepatitis Delta. So we're talking about over 315 million people worldwide with viral hepatitis. And the viral hepatitis is importantly linked to liver cancer, which we all know. It has a high mortality, and most patients in low-income countries present with late-stage disease, and over 3,000 people die daily. That is an alarming statistic. And elimination is feasible. We have the strategy, we have the diagnostic tools and other relevant tools. We have effective prevention, including hepatitis B vaccines, and transformative therapy for hepatitis C and even hepatitis B suppressive therapy. And of course, we need coordinated actions globally to optimize progress. I think I bolded This sentence, public health elimination, requires government leadership and collaboration. And this is one of the core reasons why we're talking together now with relevant program managers, officials, policymakers from ministries of health, from the 6 regions from the world to achieve elimination. So the global agenda. The global agenda is the elimination of viral hepatitis B and C as a public health threat by 2030. And elimination is defined as a reduction in hepatitis transmission and reduction in mortality by 90% and 65% respectively. I think we're all very familiar with this strategy and the 5 key interventions that will take us to viral hepatitis elimination by the year 2030. And very briefly, we're looking at PMTCT, infant vaccination, blood safety, injection safety, and importantly, testing and treatment of viral hepatitis B and C. So this global framework has been developed to measure country progress and validate achievement of hepatitis B and C elimination as a public health threat. It was developed, I am happy to say, in global consultation with over 50 experts and policymakers from 15 countries. It is a pretty complex slide, and I want to unpack it in a way that is meaningful and pragmatic and highlight 4 things. The first is the absolute targets have been developed to reflect the relative targets of 90% and 65%, which we saw in the chart. The second is the program targets have been well defined, as you will see in the 3rd row in the box on the right. The 3rd row shows the program data for hepatitis B as coverage of hepatitis B birth dose and the childhood series, as well as maternal hepatitis B surface antigen testing, coverage of hepatitis B and C diagnosis and treatment, which you all know so well, as well as other prevention interventions, including unsafe injection, blood safety, harm reduction. The third important thing I want to highlight from this global framework is the development of criteria for country validation. And these criteria include attainment of the impact target and the program target, as well as the implementation considerations. The graph on the left is a very nice way to highlight the 80% targets for hepatitis C, the 95% for hepatitis B, and the mortality in absolute terms of 5 per 100,000 persons, 4 per 100,000, and 2 per 100,000. So going forward, the terminology will be in absolute terms rather than in relative terms. The 4th important thing to mention here is that this global framework has been tried and tested, and WHO has conducted a series of elimination pilots in 7 countries, including in Egypt and Mongolia and Rwanda and UK, England, and Brazil. And the results suggest that the measurements from this framework are feasible and acceptable. And further information and the details of this framework and the details of the pilot in all 7 countries is available on the WHO website. So the WHO Global Report on HIV, Hepatitis, STI, published in 2021, includes data points from 130 countries. As shown on this slide, it shows that the viral hepatitis response has been quite progressive during the 2016-2021 implementation period of the first strategy. Now, using data from 2019, there were 3 million new chronic infections, 1.1 million deaths. And I think the major achievement is the success and achievement of the 2020 SDG targets for reducing the incidence of hepatitis B in children. And of course, we know that this has been supported by infant vaccination and prevention. We also know very clearly that timely access to hepatitis B birth dose remains low in many low and middle income countries. Again, on the right, you see this well-known chart that although the number of patients receiving treatment for Hep C has increased tenfold, the cascade, as you would see, shows major gaps in the path towards hepatitis elimination, with 21% of HCV infections and much less with Hep B diagnosed. There's marked regional variation in the response, as we can also see. Now, we know that scientific evidence shows clearly that scaling up hepatitis testing and treatment has the potential to save 8 million lives by 2030. And a new global report is expected in early 2024 ahead of the 2025 interim milestones. Now, this slide shows the new global health sector strategy, which is going to inform closing the gaps to the 2030 hepatitis elimination. It's a linked strategy for HIV, Hep, and STI, and builds on the previous 2016 to 2021 global health sector strategies. Now, the development of this new strategy is informed by many important events, including the new epidemiological data that is available, advances in science, technology, and innovation, and of course, lessons from the COVID-19 pandemic response, among others. It offers 5 important strategic directions to bridge the gap to 2030. And the 5 are listed here. And I will highlight mainly the first 3. The first is to deliver evidence-based, people-centered, high-quality essential services tailored to meet the needs of the people in diverse populations and settings. It promotes putting people at the center of our healthcare. I think previously we must confess that the diseases have been at the center of our care. So now this is replacing with people. The second important approach is taking a systems-oriented approach that promotes synergies with primary healthcare, with health systems, and of course, health systems include health governance, financing, workforce, procurement, service delivery, etc., while also fostering multi-sectoral responses and collaboration with a variety of partners, including funders. The third strategy, very key to measuring progress, is generating and using data to monitor and evaluate progress and also to guide action. The fourth and fifth include the engagement and empowerment of communities and key civil societies. We must recognize that they have a pivotal role to play in advocacy, in policy making, and in addressing stigma and discrimination. And finally, fostering innovation for impact. Next slide. As seen in the panel on the right, and I think you will all agree with me, that national strategic plans are the basis for country-led action and should be aligned with regional and global strategies that highlight the core hepatitis priorities. Now, so the national plan should therefore promote person-centered care and develop specific approach towards strengthening the country's health and community systems. In the past couple of years, we have seen many different types of national plans. Some are standalone plans for hepatitis or TB, while others are being increasingly integrated with these common infectious diseases and other nationally relevant diseases. I am pleased to see several countries represented in these webinars, and we have worked with them for costing national plans and reviewing national plans, and these are being used for advocacy and resource mobilization. Now, the strategy documents also provide new interim estimates for 2025 and absolute targets for both 2025 and 2030. I mean, this reinforces the importance of data for the measurement of progress and country action. This is an interesting slide. The next slide, please. Substantial progress has been shown and can be achieved by implementing the new actions under the strategy. And just want to highlight a few things on this slide. On the left panel, as you would see in the solid green lines, the decline in incidence and mortality trends for both hepatitis B above and hepatitis B below from implementing these new strategies are significant compared to the status quo as represented by the dotted lines. On the right side of the panel, you will see that the cost of elimination is huge. and is estimated to be over $3 billion in 2022 and peaks at $8 billion in 2028. However, it points to commodities as key determinants of the overall price tag, and reductions of these costs will be critical to progress. And we're talking about commodities like laboratory tests and drugs. We know that many countries do not have major donor funding. Actually, globally, there is a lack of major donor funding. So the government funding has to provide momentum for change. And this has been well demonstrated in several countries, including Egypt and Rwanda, and can be supported by catalytic and other sources. Now, the recent Global Fund information notes for HIV include viral hepatitis as a comorbidity, and some countries may have a rationale to access this within the country allocations. In terms of progress towards eliminations, I think, again, this is a familiar slide, and we have learned key lessons and a lot of creativity in achieving results in hepatitis champion or early adopter countries within the WHO regions, as shown on this slide. Outstanding political leadership from Egypt to domestic financing within UHC in India, and measuring reduction in Australia are important endpoints. Some countries are also demonstrating progress even outside this map with implementation pilots that can be accelerated and scaled up in scope, in scale within different programs. Now, linking and integrating core viral hepatitis interventions is feasible, and some natural entry points include common service delivery platforms, such as with triple elimination of HIV, hepatitis B, syphilis, integrated harm reduction clinics or programs, which has been well demonstrated in certain of the countries present on this platform. Now, inclusion of priority hepatitis prevention, care, treatment services into essential health packages is a powerful mechanism for influencing service delivery. And new WHO recommendations promote this person-centered care and service simplification and integration. And just to mention a few, includes the HCV self-testing and the consolidated key population guidance that was released in 2021, and the amazing HCV diagnostics and service delivery that was released this year. And they provide radical simplification. They are based on scientific evidence, and it's been demonstrated that they can be implemented at different points of entry into the health system, including primary care, harm reduction sites, and prisons and HIV clinics, as well as community-based clinics. Now, the evidence base for these recommendations are shown on the screen. This is one of them, with 142 studies from 33 countries showing very well that decentralization is feasible and has an advantage over non-decentralized services. The acceptability by end users has also been evaluated, and further information on evidence is located on the WHO website. There are different approaches to implement simplified service delivery, and I think what I'm going to highlight from this slide is the need for joint planning and coordination, which underpins implementation and change management. Change is hard. We look forward to the presentation from India to provide further context and substance for integration. They will tell us how they have done it. Next slide. So this is an interesting slide, and it's reflections from our hepatitis program officials and policymakers from over 30 countries that joined us here in Geneva in June 2022. We have curated a few of the comments, and one of the comments, I'll highlight one or two. Many strategic plans remain theoretical, uncosted, and inadequately financed, and program managers thought that plans should be aiming for integration from the start. The last in red is, it was interesting to note that significant benefits in developing a platform for sharing country experience and learning was one of the key feedback from this meeting. And this is part of why we are holding this webinar for countries. So what is coming? What's hot in 2023? And many things are ongoing. 4 of them are mentioned here, and one is the update of the hepatitis B guidelines, including expanding eligibility criteria and simpler service delivery, even within PMTCT and antenatal care system. We shall be updating the interim guidance and developing what we call a path to elimination for hepatitis B and C, especially in high burden countries that may not be able to reach that absolute target, but are already reaching the relative targets. The third is the consolidated guidelines of all the strategies. And of course, we will continue to provide country support, technical, strategic, financial, just to highlight that the Global Fund initiative is providing a lot of guidance at this point for country allocation, and colleagues and partners have developed a toolkit that will assist countries to identify the adequate and the relevant priority for their context, and that we will share in subsequent meetings. And on that note, I would like to thank you and highlight 3 key messages. Viral hepatitis needs to be and remain a public health priority. Person-centered care and linkages and acceleration have been shown to accelerate progress, and government commitment is key. In fact, there is an important role for program officials and policymakers, and I hope we can all work together to co-create value and leverage our collective knowledge. And I want to thank the entire Department of HHS, the Global Hepatitis team, and all the members and all the colleagues from the Ministries of Health in countries in all the 6 regions. So thank you very much, Diana. And on this slide is a quick poll. We would like to know more about your country. And the first question is, does your country have an official national hepatitis strategy? This is on the screen, and please, Romina, can you put this on the screen? Yes, it's on the screen, and the question is, does your country have an official national hepatitis strategy? And it's interesting to see all yeses and there are no nos. We need to have nos. I know that science is not 100% exact. So of the 27 countries answering, the answer is yes. We need more responses. Yes, now we have a no. It's amazing that I'm excited about a no, because already we are identifying opportunities for support. So of the 34 responses, 94% of the people have strategies in their countries, and 2 countries do not have strategies. Please make sure you type your country in the chat so that we can follow up with you. The second poll question, and this is a little bit more specific, is the national viral hepatitis strategy in your country. Is it a standalone strategy, or is it a program linked or integrated with other programs? Romina, please put on the poll question number 2, and we eagerly await your response. Is it a linked strategy? Is it an integrated? Is it standalone? And I see here that already nearly 80% of strategies are linked. That is really great. There's so much experience from COVID-19 that shows us that linking systems and strategies may be the way to go. And of course, this is reaffirmed in our global strategy. So out of the 35 responses, or 37 received so far, 65% are integrated or linked, 23% are not linked, and 10% they do not have a strategy. And on that note, I want to thank you very much for your responses. And the responses again are shown on the screen. Okay. So at this point, I would like to invite Dr. Cabra to the screen.
Good
And
afternoon.
I just want to start by saying that India has a huge population and is making great strides in this hepatitis response. And there are so many lessons to learn from the experience. We're honored to have you, Dr. Cabra, and you have the floor. Thank you.
Thank you very much for me. Good afternoon, everyone, and good morning to some and good evening to some. On behalf of India, myself and Dr. Partha Rakshit, my Joint Director, will speak on behalf of the National Viral Hepatitis Control Program. Next slide, please. Next. So India's response has been aligned with the Sustainable Developmental Goal 2030 using the existing health systems. Next. So India is a large country. Next. And we have a federal structure. We are divided into 36 states and union territories. Next. If I were to expand on one state, we have multiple administrative units called districts inside one federal state. Next slide, please. And inside this state, we have our health sector structure going right up to the sub-center or below the primary healthcare level. So we have the district hospital, then we have community health centers, primary health centers, sub-centers, and health and wellness centers. Next slide, please. So the National Viral Hepatitis Control Program was launched within the ambit and within the existing health systems on the 28th of July, 2018. With adequate advocacy, it was launched by the political leadership of the country to include treatment services for hepatitis C. The same was expanded to include services for treatment of hepatitis B in February 2019, when we also launched our helpline in collaboration with the TB program, and we launched a paperless management information portal and system. Next slide, please. A little bit about the process. The most important thing that I want to focus over here is the conceptualization of the program was from the very beginning within the health systems. We involved all stakeholders, technical experts, and community. And we prepared working groups from across the country. We had 10 working groups in various areas. We electronically worked and culminated in a physical meeting. And that is what lay the foundation of our National Action Plan. The program got its approval with 100% domestic funding, making it very sustainable. Next slide, please. So as you can see, we've used the universal health coverage umbrella for the viral hepatitis. We ensure access, we address quality, and we do have domestic funding, so we ensure financing. If we look at this slide, the blue piece is actually what is offered by the National Viral Hepatitis Control Program, and the brown shades in the peach is what is already existing in the health system. So the program itself provides for prevention, diagnosis, management, capacity building, along with an all-encompassing monitoring and information system. We have very close collaborations with the Reproductive and Child Health Program, with the Immunization Program, with the National AIDS Control Program, with the Safety of Blood and Blood Product Program, and surveillance mechanisms already existing in the country. Next slide, please. So a little bit about the structure in the country. It is divided into the national structure, the state structure, district, and sub-district level. What I want to highlight over here is the role of the steering committee. The role of the steering committee at the national level is very important, because if we have multiple verticals addressed in the steering committee headed by a senior administrator, we get the focus and attention of many verticals existing within the government systems. And the formation of the steering committee is very critical for putting up a good program with appropriate advocacy to get allocation for finances in the country. The other important piece is involvement of technical experts while making policy. So both these things are very key component in our program at the national, at the state, and even at the district level. The rest of my presentation will be a little more focused on the below district level, because that is what we are aiming at, decentralizing and reaching the last man using the health systems. Next slide, please. So a little bit on the integration with the existing reproductive and child health program. Everything that you see in green is something that was already existing in the country in terms of the infrastructure, in terms of the manpower, in terms of the presence on field of a healthcare facility. Everything is blue is what we provide. So what we have done is we provide screening kits for hepatitis B surface antigen and capacity building at the lowest level of healthcare centers. And anyone who is tested positive has a linkage to a referral health center. Here again, we integrate closely. We provide for the hepatitis B immunoglobulin, which is given to the baby within 24 hours of birth. And we integrate and collaborate closely with the immunization program, which provides for the birth dose of the hepatitis B vaccine. The other thing that we do at this point is we counsel the woman, the pregnant woman who has come positive, so that she comes for further linkages with the hepatitis program for management. Next slide, please. Similarly, we are integrating with the existing AIDS control program. In green again is what we already have in our health system. What is in peach and brown is what we are offering to integrating with the AIDS control program. So we provide for testing and treatment site under the AIDS control program, and we do hepatitis B and C screening at both the ICTCs and the ART centers. Similarly, at the targeted intervention sites where we have the high-risk populations, we provide them two options. Either it can be a camp-based community-led approach, or they can approach the health facility where we can provide for testing. In both instances, we use the already existing systems, manpower, etc., by providing only the very basic screening kits and a little bit of capacity building and the hepatitis B the hepatitis B vaccine to all the high-risk group who test negative on screen. So this is a very innovative thing that we do. We screen all the HRGs, and anyone who tests negative for hepatitis B, we immunize in a camp-based or a facility-based approach. Next slide, please. So this is our integration with the ongoing surveillance program. We have two types of surveillance. One is the population-based surveillance, the active and the passive surveillance. The passive surveillance data we get from our own program through our MIS and through our monthly reports. We are integrating closely with the HIV Sentinel surveillance program run by the National AIDS Control Program. We have already had one round with them, and we propose to integrate in the next round, which is going to start next year. One of the very key things that we have done is we have a huge population-based survey called the National Family Health Survey. We have integrated into the National Family Health Survey, and we are able to get and gather data on the biomarkers of hepatitis B and hepatitis C. We also propose to do the under 5 surveillance to have some kind of a goalpost towards our elimination targets through this population-based survey. Next slide, please. Now, this is integration with other existing mechanisms, infrastructure, and manpower. It is very important to understand that we collaborate closely with the tuberculosis program because they own a lot of infrastructure in terms of the viral load testing machines. We also integrate closely with them in terms of using their call center helpline along with the hepatitis. We integrate with the psychiatry departments of the hospitals where we request psychiatrists to help us trace and track people who are under substance abuse for us to be able to reach them and be able to screen them. We also integrate closely with the existing mechanisms of procurement and supply chain management, whether it is the system of procurement, the system of logistic and supply chain, or cold chains. We use whatever is the existing mechanisms and provide for no financial expenses. As this is not a vertical, we cut horizontally with these systems. Counseling services at our district level, we have multiple counselors under multiple programs. The program does not offer for any separate counseling facility. However, we promote for an integrated structure in the district hospital and all relevant counselors to come under one roof to be available for everyone to be counseled. We also collaborate closely with the program on hemoglobinopathies, thalassemia, and sickle cell disease. We treat them as high risk because of the multiple blood transfusions. We promote screening on a 6-monthly basis for them and to identify any infections and then link them to the program. We also closely integrate with an existing integrated disease surveillance program for hepatitis A and E, which is also under the ambit of the National Viral Hepatitis Control Program in India. We are closely collaborating with prisons. We are doing a lot of screening amongst prisoners and trying to capacitate the medical officer and the laboratory technician existing in the prisons such that the treatment of uncomplicated cases can happen in the prison itself without movement of the prisoner outside. In the private sector and public sector, we are collaborating in a decentralized manner with de-addiction and rehabilitation centers so that we can get a quick check of hepatitis B and C surface markers on or in these people. And then if anyone is found positive, they can be linked. Similarly, with the dialysis control program, we have on our radar the cancer control program, but we are yet to integrate with the cancer control program to include their registries and have closer tie-ups. Next slide, please. So some of our innovations, we feel that the way we use the steering committee is a very, very effective way of trying to pool finances, pool resources across departments and ministries, and everyone speak in a common voice. Intersectoral coordination committee is something that we made, and we had a working group under this intersectoral coordination committee where each and every sector that cross-cuts with hepatitis is involved, and we have a quarterly meeting and we minutize and follow up the needs and how better to implement the program. Vaccination of HRGs, I already talked of. We also give best performing awards year after year to various states and UTs who perform well. Moving towards district level planning and monitoring mechanisms, we are using the existing manpower by minimum incentivization and building their capacities. And we are motivating the district and state administration to make hepatitis B and C as reportable disease, thereby engaging with the private sector on not having to repeat anything. Next slide, please. So this is our coverage. The map is in two colors. 100% district covered, that's the light blue, and the lilac is less than 100% district covered. So you can see most of the country we have covered, all the states are covered. If you see the second map, you can see the dark blue and the light blue. The dark blue is where we've gone below the district level as I defined in my health system slide. And today we have 900 treatment sites established across 98% of the districts. We have screened 47 million people starting 2018 July. We have initiated and treated 0.18 million people and trained roughly 2,200 master trainers across the country. Next slide, please. Of course, anytime you begin implementation, there are many challenges. We have a large country with a huge geographical expanse and large population. Health is a state subject because we are a federal structure and the state can prioritize the areas in which they want to park their resources. So every time we cannot have a standardized approach across the country in a uniform fashion. For kits and drugs, logistics, cold chain, quality, limited manufacturers of whole blood finger prick tests, expiry of drugs due to COVID-19 remained a challenge. But here, I would like to mention, we initially did centralized procurement for efficiencies of cost. We decentralized, we thought it would be better, but we are thinking of re-centralizing. So what I really want to say is that even though it is tough at a single point to begin the procurement, but I think to monitor the quality, to have sufficient amount of drugs and kits across the country, it is very important to have centralized procurement to be able to meet with the material needs of the field units. Our MIS, even though when we started the management information system, we thought it would be great, it would be paperless, but we are seeing that we have some fields related to the physicians, and it is very difficult to sensitize physicians to capture data. And sometimes they only make the positive entries, so it skews the data when we as policymakers try to look at it. Next slide, please. So our plans for the scale up, we are focusing on the district as the administrative unit for decentralization of the program. We establish a monitoring mechanism under the district leadership. We want the system of MIS to be completely paperless. We continue to physically handhold and capacity build on site. And we have begun teleconsultations for far-flung areas where people cannot reach, especially the complicated cases. Next slide, please. Thank you very much. My presentation would not be complete without thanking my team, all my officers, my consultants, my nodal officers across the country. Thank you very much.
We thank you so much, Dr. Cabra, for this fantastic presentation. It's Dr. Niklas Luhmann joining from Geneva. I will now lead our discussion time where we will quickly hear as well from Egypt and then move to discussion with the participants. Dr. Cabra, I think really you have absolutely championed the concept and implementation of an integrated response in HIV, surveillance, sexual reproductive health, and many other areas. It is very impressive to see that, and we thank you for bringing that to the group. I will now hand over or welcome Dr. Wael Abdelrazek. He's a professor of hepatology and gastroenterology at the National Liver Institute in Egypt, and he heads as well the primary healthcare and nursing sector program at the Ministry of Health. I think Dr. and Professor Abdelrazek, we all know the very, very impressive globally biggest hepatitis C elimination program has been implemented in Egypt, where around 50 million people have been screened since 2014 and many more than 1 million treated for hepatitis C. Today we wanted to ask you a question around integration within and through that program. So my question to you was, noting your very impressive and important elimination program, you have as well used it to integrate the screening of other chronic disease. Can you please explain what chronic disease screening and management you integrated in your national hepatitis C response and how this was done? Please share as well any main challenges for this approach if there were main challenges occurring. Thanks for joining, Professor, and over to you.
Thank you very much. Good morning and good afternoon to everyone. The chronic diseases which were integrated in the screening program were diabetes, hypertension, and obesity. We used the 20 minutes window for waiting to the rapid detection test for doing the HCV as an opportunity to maximize the benefit from this visit. We used glucometers for diabetes with the blood pressure measurement and the weight, height, and calculation of body mass index to categorize the population according to obesity. I think the main challenges were the referral. The main focus of the country at this time was the HCV. So everything was behind HCV. So the referral was not, did not have the main, it was not in the main focus as the hepatitis C. So most of the patients or part of the patient were not interested in this referral. They were interested in hepatitis C and getting rid of hepatitis C, which is a newly diagnosed person who did not have the knowledge of having HCV before. The other challenge was the electronic records. For hepatitis C, we have electronic records from the screening till the SVR till the surveillance for HCC later on. But in diabetes and hypertension and obesity, it's not the same situation. Other is the four up of the national guidelines. The dynamicity of the guidelines for hepatitis, viral hepatitis, is very, very strict. With every medication or every test, we update our guidelines for viral hepatitis as it is a national goal. But later on, we learned from these lessons. So we shifted to viral hepatitis B. Hepatitis B prevalence in Egypt is less than 1%. So we updated our national guidelines. We have national guidelines. We updated our SOPs, and we focused on vaccination of all relatives. And all through, we have dynamic numbers of viral hepatitis centers, according to the flu. We started in 2006 with 3 centers for treatment of viral hepatitis. Then during the initiative, we reached around 150 centers. Currently, we have around 70 centers. So it's dynamic according to the flow and the prevalence of viral hepatitis. We started the program for HCC surveillance in patients with cirrhosis, whatever the etiology behind the cirrhosis. We started negotiations with pharma for prices, and we launched guidelines for the systemic therapy for HCC to be free for all Egyptian citizens. And we used the hepatitis elimination as leverage to strengthen every aspect in the portfolio of the viral hepatitis portfolio to be submitted to the WHO, and to ensure the sustainability of these processes. We integrated with blood banks. We have the national ID, which is a blessing in Egypt. Through the national ID, we can identify if this citizen has hepatitis B, hepatitis C, or HIV. So once the screening of the national ID defines that he's already infected, or he has the antibodies or S antigen for HCV and HPV respectively, he is excluded from the donation. Otherwise, we waited for the donation and the test to exclude the blood bag, which is cost effective for us. We started and focused on harm reduction, the needle syringe program and the OAT, which was not that easy previously. And with the help of NGOs, we reached communities that we could not reach before. We shifted from the mass screening to high-risk screening for incarcerated people in addiction centers, frequent blood transfusers, patients on dialysis, people who inject drugs, people living with HIV. We started screening in PHC during the antenatal care for hepatitis B, HIV, and syphilis for the triple elimination. And we launched counseling, especially mental health counseling for the pregnant ladies. This was integrated in the PHC. Then we have a specific initiative for NCDs. After the initial data from the initiative, we have an initiative for NCDs and an initiative for chronic kidney diseases. NCDs, we used point-of-care tests for A1C, for lipid profile, and a point-of-care test for estimated GFR. With the scientific committee, we updated the guidelines to include guidelines for the PHC to manage the the NCDs and the other levels of services. We used telemedicine during the initiative for remote areas, and currently we use telemedicine in other purposes from the PHC and from other hospitals. Currently, we are reforming the PHC to embed initiatives and integrate it with already their programs and services. And we are aiming to embed all this in the universal health insurance, which is the ultimate goal of the healthcare services in Egypt. Thank you very much for allowing me to highlight this. Thank you.
Thank you so much, Professor Abdelrazek. That is really amazing. And I think both presentations from India and yours highlight just amazing opportunities in a health systems approach to make progress on hepatitis elimination, but as well many other program areas, and serve most vulnerable populations and across many other disease areas. Really, really amazing. So now we're really going to the discussion time. So if you can all put your videos on, if you don't mind, and if it's possible for you, I just wanted to remind everyone as well that it's really an interactive session. We have 15 minutes left, and now it's your session in terms of bringing any questions or experiences to the group. So I would ask people online, you can as well, if you feel more comfortable, to post something in the chat. My colleagues are monitoring the chat, and or you raise your hand, and please, maybe to start with, if there's any clarifying question to the WHO presentation from Dr. Leshi, from the India presentation from Dr. Kabra, or from the Egypt intervention, you can ask any clarifying questions if you have them. I don't know if anyone feels to go first. Wonderful, I see one hand up. Dr. Omutisi, is that right?
Yes.
Please. Thanks for
Yeah,
joining
you.
and starting the discussion.
Okay, thank you so much. I thank the presenter from India. I have two questions to her. The first is about she said they are planning to monitor viral hepatitis among infants below 5 years. I would like to know what they are planning to do for this population, which I consider they are very important in eliminating hepatitis B especially. My second question is also addressed to the Indian presenter. It's she said they focus on prisoners and integrating viral hepatitis strategies. I want to know whether they systematically screen for hepatitis for every prison every new prisoner, if they systematically screen, because they said actually they don't need to go to the health facility to take medicine. Do they screen systematically? Do they vaccine every new prisoner? Thank you. And the other one, another question is addressed to the professor from Egypt. I would like to know what is the reason behind the low prevalence for hepatitis B in Egypt, because I know HCV is very high. Thank you.
Dr. Omutisi, could you just quickly say where you're from and what your role is in your country so that we know who you are? Thank you.
Yeah, thank you. Thank you so much. I'm from Rwanda, Rwanda Biomedical Center. I'm working for Rwanda Biomedical Center and in hepatitis unit. Thank you.
We thank you so much for the questions addressed to India and Egypt. I don't see any other hand up. Is there anything in the chat in the moment? So we could bring that in already, or?
Yes, there's a comment on funding, how India was able to sustain its funding. And I think it's important if we could hear from Dr. Kabra, because I think that is very key for sustainability of hepatitis programs.
Fantastic question. I had noted the same one. Dr. Kabra, you said everything is domestically funded, and I think that's a question that many programs have. So if you could expand on that and even say if you made the case, how you made the case, how that worked to get that engagement, I think that's a fantastic question. So the questions from our colleague from Rwanda, plus the one on financing, thank you, Diana, and one to Professor Abdelrazek. Thanks first to you, Dr. Kabra. If you heard well, I hope all the questions.
Yes, thank you, Nicholas. So I'll take the first question from my colleague in Rwanda with regards to the surveillance in populations less than 5-year-old for hepatitis B. So as I explained, we are using the already existing National Population Health Survey. We call it the National Family Health Survey. And that is it's a very structured kind of a survey existing in our country for many years. But what we have done is we have validated the dried blood spot collection. And so now what they do is that when they are doing the survey, population with 4 to 5 years has been identified. And a statistically significant number of people, children between 4 to 5 years, their dried blood spots will be collected, and then they will be screened in a centralized manner at one laboratory where this validation has been done. And the data that we can get will give us a large amount of information, and we will not need to spend any money, any additional resource on doing a survey like this across a country like ours, because it's a huge country. So that is the first question. And the second is with relevance to the prisoners. Yes, no, we are not all out there in the sense we haven't screened every prisoner. But yes, the strategy and the policy is that everyone who is a new entrant into the prison is screened. And anytime they are released on bail, we do try, because some of them are not really convicted, but we do try, if they are screened positive, are connected to that particular state and that particular district where their treatment can be followed up if they were positive. And at present, we are focusing on the high-risk groups like the IDUs and the TBs, the FSWs and the MSMs for the vaccination. We haven't begun a full-fledged vaccine campaign for prisoners who screen negative for hepatitis B. So this is for Rwanda. And the other question on financing. So when we began to conceptualize the program, we understood that if to any policymaker or to any financer, we put forward the whole cost of the program, it looks humongous and it looks like it just cannot happen and it cannot be done, especially in a country our size. So we broke it into pieces. So what we did is that we saw what already was existing in the reproductive and child health. We realized that the immunization was already available. And one thing that I forgot to mention in my presentation, but I think I would like to mention here, is that we are immunizing all the healthcare workers. So we just asked the immunization division to bear the cost of the healthcare worker immunization. And we also supported them by starting to monitor the 0-dose vaccine that they were already giving. So that way we piggybacked on existing resource. They had procurement mechanisms. They had very cheap rates because they were engaged in the universal immunization program and they were already getting the vaccines at the best possible rates. They had their cold chains. They had their whole monitoring system. So we just piggybacked on that. Now with the National AIDS Control Program, again, they already have a full-fledged structure of targeted interventions. They have identified the key populations. They're already doing the needle and syringe exchange program. We just piggybacked on them. We said all ICTCs, all ARTs, all HRGs become our target. And this is where we are going to just provide the capacities and provide the testing kits, which are just screening testing kits. And once anyone is positive, then we are going to take them in the ambit of the program. So that also saved us a lot of infrastructure and human resource cost. Again, everything that we procured, there was already a mechanism existing in the ministry. We just added an additional indent and procurement request for that. So that got taken care of very easily. We did central procurement, use the state warehouses, again, which were already existing, the supply chain mechanisms already existing, and we just did a little bit of capacity building to see how best we could use this. The management information system was already existing in one of the states. We just polished it up to our needs with minimum investment, and we acknowledge the support of the Clinton Health Access Initiative for supporting us for this and making it possible for us to do this. With the blood and blood safety program, you're all aware it's a regulated product. It is regulated in our country also. As our other TTIs, hepatitis B and C screening is already happening. We train the counselors and we are requesting them, any donor screened positive for hepatitis B and C, we made a policy change. The result has to be disclosed and that donor must be counseled to come to the NVHCP for further management. The TB program also existing. So if you really see, all this was already existing by just a little bit of capacity building a monitoring mechanism, which means in any facility, and this is where we are going at the district level, we are saying that the chief of the district, the medical chief of the district must review on a monthly basis, keeping all these stakeholders in mind and keeping the agenda of viral hepatitis in mind. And the same we are saying to the district administrator that every 3 months, he must review it as a very important health agenda. And by doing this, we don't really have to go everywhere. We don't need to employ any additional manpower in the field, and we can sort of piggyback on whatever was existing. So when we made this proposal like this, with zero infrastructure cost, only consumable cost, it was very much and very well received by the administrators, and the political will was generated, and we were in a position to roll it out very quickly. And maybe by the time we conceived and by the time we rolled out with full financial funding, it was hardly a period of 18 months. Thank you very much.
Thank you, Dr. Kabra. It's an amazing experience. Dr. Razek, I didn't forget about the question for you, but I will bring in a last round of questions because Dr. Pascal Tiamala has his hand up. Please ask your questions, and we have to go towards the end of the webinar. So I will take your questions and the one in the chat in French, and then we will have the response, and I will hand back over to Dr. Lissi.
Merci beaucoup. C'était formidable cette conférence.
Thank you very much. This conference was absolutely amazing. Oh, is actually. And I just wanted to ask the question to Professor, the Egyptian professor who presented on the Egyptian program. I just wanted to know whether the program of medicine sharing that they proposed and suggested a time ago, if this program is still ongoing. Because next year, here in the DRC, we are going to start our program of the priority issues. We have a strategic plan, national strategic plan, and in this, including in this plan, we have identified 10 priority issues, of which the cost of the screening, the cost of the medicine and the screening. And I would like to know whether this program still exists and whether this is still ongoing in Egypt, and also if there is a similar offer in the world that exists with regard to the screening test. Thank you very much. Okay. Thank you very much, Dr. Pascal.
To use the translation, Dr. Razek. If not, I will repeat. So this is a question to you about the hepatitis C program in support in other countries. And then there is one other question in the chat from Dr. Mbela in Cameroon, who I think is asking a very nice question to India as well here about diagnostics integration, and asking really how was your strategy to use diagnostics platform, I think notably virological molecular platforms for viral hepatitis. If you have any, maybe as well, a comment including expansion of virological molecular platforms in COVID, that could be nice. So 2 questions to you, Dr. Razek, on hepatitis B prevalence and your support program in hepatitis C and diagnostics integration to Dr. Kabra. Professor Razek?
Thank you for the questions. For the first question, the vaccine, I think is the hepatitis B vaccine is the solution. We started the program for hepatitis B vaccine since birth in 1992. The birth dose was in October 2014, and the vaccination of the healthcare workers. The gap was the mother-to-child transmission, and we started in 2020 the prevention of mother-to-child transmission through the antenatal care screening for hepatitis B, HIV, and syphilis. And we use a combo test with a single drop of blood, which is much easier. And we are starting next February premarital screening, and we will include hepatitis B, hepatitis C, HIV, and in the premarital screening to start earlier than the pregnancy. This is regarding hepatitis B. Alors, si vous avez la question.
You have the question with regard to the screening. With regard to what we did, as I'm the chair of the African Union, we help all the African countries, and we're here still. This help is still available for screening and for treatments.
PCR and virological testing. After the screening, patients were referred to the treatment centers. The first step was the blood sample for the PCR, and we have more than 27 machines all over Egypt to have the PCR connected to the lab information system, and to have the result in the treatment center once it's recorded in the LIS in the lab system. And through the COVID, we shifted some of these machines to help in the COVID era. Thank you very much.
Dr. Cabra, back to you. If you have any comment on the diagnostics integration. Was that question clear to you? Dr. Cabra?
She's on mute.
No, she's not. Amy, can you still hear me? Dr. Cabra cannot hear us anymore, I think. Dr. Cabra, can you still hear us?
Am I audible?
Ah, yes.
Now, yes.
Yeah, am I audible?
Yes.
Yeah, now it's fine. Thank you. Oh, I think you have an echo now. Maybe you have to turn one device off.
I'm sorry, actually, we lost connection for a moment. Yeah, so with regard to the viral load testing facilities, as I said, we didn't invest anything in the new viral load machines. So there was a large amount of infrastructure existing with the tuberculosis program.
That's a pity. I think we lost them again. Let us see if they can join again. Otherwise, maybe in the meantime, Dr. Lisi, if you can start to say as well, there's another poll and we can see if the Indian colleagues join again.
Yes. Okay. Thank you. Thank you very much, Nicholas and Dana. The interaction has been really energetic and really.
Can you hear me? I'm sorry, I'm having some connectivity issues.
Okay.
Should
We
we?
can hear you. We can
yes,
hear you.
we
Give
can.
you 1 minute maybe to wrap up.
So
we
was
can close.
I audible and could I communicate? So we have multiple strategies. We have a centralized hub and spoke model. We prefer to use the closed systems because of the coming of COVID. A lot of kits have begun to come in the market and a lot of systems, until we validate them, we are not very sure whether we want to use them for hepatitis B and C. So we have taken a conscious call on not using the open systems right now. But for the closed systems, we have a large amount of systems existing to the district and the sub-district level with the TB program, which we are using by providing for the consumables. And also we are using the hub and spoke model for the high throughput machines at our medical schools, where the samples are being referred, not the patients. Thank you.
So thank you very much, Dr. Cabra. We are actually running over time. And I must say that this interaction has been energetic and dynamic. And we would like to establish a collaboration and co-create content. So we appeal to you and request that maybe you write in the chat the topic areas or the programs that you would like to discuss in the coming year. Already we have some in the chat and they have highlighted some countries want to hear more about successes from countries with a focus on challenges. We've seen the question and the request for more information on triple elimination. It's a powerful tool to ask questions and maybe to share what you are interested in learning. So please put them in the chat, keep them coming to help us to devise how best to meet the needs of every single participating country in the coming year. I think it's been a great session. We thank very sincerely Dr. Cabra from India and her team, and Prof from Egypt and his team. We see the audience engagement, and it is great to hear the success from your countries. And we would also put a poll on the screen. Are we using the poll anymore? No. So we're not using the poll anymore, but we want your contribution in the chat. We note that there are some unanswered questions in the chat, and we'll be getting back to to those questions, and we will communicate with countries that are requesting for assistance for the national strategic planning. So on behalf of Dr. Meg Doughty and the entire Global Hepatitis Program team here in Geneva, we thank the Ministries of Health from the 36 countries represented on this platform and our dear colleagues from the country offices and WHO's regional offices. We would like your feedback and would like your comment on how to improve this platform for a sustainable engagement. And on that note, I say thank you for joining us. It's 10:25 at this time, and we appreciate the time you have spent. It is about you. We want to engage with you, and we want your feedback on how to move forward. So thank you, everybody, and have a lovely week ahead. Thank you, and over. I thank also Project ECHO that has been substantial in providing this platform and supporting the preparation and the presentation. So Amy, to you and your entire colleagues, we say thank you. Thank you very much, everybody.
Thank you.
And bye. Thank you.
Yes.